Hello, and thank you for that introduction. Again, my name's Jean Nappy. I'm professor of clinical pharmacy and outcome sciences at the South Carolina College of Pharmacy at the MUSC campus in Charleston. And it's my pleasure to speak to you about acute coronary syndrome. So let's begin by talking about the magnitude of acute coronary syndrome. In 2010, the American Heart Association published its heart disease and stroke statistics, and the estimated number of hospital discharges associated with ACS was over 700,000. The vast majority of these were patients who were diagnosed with myocardial infarction, and about 86,000 of these hospital discharges were attributed to unstable angina. I'd also point out that more than 1.3 million procedures for inpatient procedures for percutaneous coronary intervention were done. And many of the patients who present with ACS do go to the cardiac cath lab and probably undergo one of these procedures. So let's further clarify definitions and review what exactly is acute coronary syndrome. Well, it's defined as either unstable angina or myocardial infarction. Unstable angina is an increase in the frequency or duration of ischemic episodes, and it's generally caused by an imbalance between oxygen supply to the heart and the demand of the heart for oxygen. Generally, it involves a non-occlusive thrombus, and we'll review that and have a picture in another few slides. The differentiation of myocardial infarction is that with infarction, you actually have cell death. So it's irreversible tissue necrosis. And this is usually due to an occlusive thrombus, meaning that the thrombus is so large in the coronary artery that it's obstructing blood flow to the point where the cells distal to the obstruction die. When a patient presents with acute coronary syndrome, they're generally coming in complaining of chest pain or perhaps chest pressure or tightness, and they often will have other signs or symptoms that go along with myocardial ischemia. Now, most of the time when they initially present to the emergency room, we can't really determine whether the patient has infarction or whether this is unstable angina. Again, unstable angina means that the ischemia is reversible, whereas with infarction, it's irreversible and there's cell death. So what happens is after perhaps 6, 8, 12, 24 hours, somewhere within that time frame, the diagnosis is actually made, and it's primarily made based on whether the serial markers in the blood indicate myocardial injury. Another option, of course, is if the patient presents initially with ST segment elevation on their electrocardiogram, and in that case, they're given a diagnosis of ST segment elevation MI. In any case, having sort of this umbrella term of ACS is useful because, in fact, patients with unstable angina and acute MI are generally treated in a very similar manner. So the underlying pathophysiology is that we have an atherosclerotic plaque. The patient has coronary artery disease. They may not know it. This could be their first presentation, but they do have coronary artery disease. And with acute coronary syndromes, something has happened to make the plaque rupture. When the plaque ruptures, this really initiates the clotting cascade. And in addition to the coagulation beginning, we also have release of vasoactive substances, which causes vasoconstriction of the coronary artery. This further reduces blood flow distal to the lesion. So we have release of epinephrine, thromboxane A2, ADP, and thrombin. And all of these substances also are agonists to the platelet, meaning that they activate the platelets so that the platelets begin to adhere to one another as well as to the vessel wall. That is the first step in the thrombus formation. Once the thrombus grows, now we have myocardial oxygen demand of the heart exceeding the blood supply, further leading to ischemia. So this slide just demonstrates in a diagram or picture what we're talking about. On the left-hand side of the slide, we show a lesion that is described as stable, and so the patient may have signs of ischemia, chronic exertional angina, when they exercise and the heart is working harder and requires more oxygen. But at rest, the lesion is stable and has a thick fibrous cap. The diagram in the middle of the slide shows where the fibrous cap that covers this atherosclerotic lesion is very thin, and there are a lot of macrophages, and there's a big lipid core. These kind of plaques are called vulnerable plaques or unstable plaques, and it doesn't really take much to have this fibrous cap rupture. And in the next picture on the right-hand side, you can see where now there's fibrin, white cells, red cells, platelets, and we see a dark area. This is the beginning of a thrombus, and that thrombus could potentially grow to the point where it might totally occlude the vessel. So the consequences of acute coronary syndrome can be quite dramatic and severe. We are concerned that this thrombus may grow to the point where there is enough blockage such that the patient actually develops a myocardial infarction and we have muscle dying. This could, of course, lead to either acute or chronic heart failure. Another major consequence of acute coronary syndromes are arrhythmias. In fact, the patient could develop ventricular fibrillation and have a cardiac arrest. So the consequences of ACS can be quite severe, potentially fatal. So it's very important that we treat these patients emergently as well as prevent any future events. When patients present to the emergency room, there are a number of things that should be done very quickly. The first thing is that a 12-lead electrocardiogram should be placed and an IV established. If the patient has not already chewed 325 milligrams of aspirin, that's done right away as well. And usually IV nitroglycerin will be started unless the patient is hypotensive. Then, of course, we will draw blood to see, to get some baseline cardiac markers. And what I mean by that is we're looking for troponin as well as CK values or creatine kinase. Those are markers of cell death within the myocardium. Once we've done that initially, we'll look at the electrocardiogram. If the electrocardiogram is normal, and if after a number of hours the blood for the serum markers comes back normal, then you need to assume that the chest discomfort was probably due to some other cause, not cardiac, but but perhaps, musculoskeletal or something. If the ECG is initially showing signs of ischemia, then we, of course, are very concerned about acute coronary syndrome. And in the right-hand side, if the EKG actually shows ST segment elevation, then this patient is immediately given the diagnosis of an ST segment elevation MI. They're usually treated emergently by going to the cath lab. Even if it's 2 o'clock in the morning, cardiologists are called in, the cath lab is mobilized, and the ideal is to get that artery open within 90 minutes of the patient coming to the emergency room. On the other hand, if the electrocardiogram shows signs perhaps of ischemia but not ST segment elevation, then they're generally treated medically, at least initially, and probably would go to the cath lab as not as an emergency, but perhaps when, during normal working hours. As I mentioned, most patients are probably going to be going to the cath lab and undergoing a percutaneous coronary intervention, or PCI. And even if a patient goes to the cath lab electively, let's say they have stable angina and we're just going in to reduce the size of a stable plaque, even in those circumstances, having a PCI does predispose the patient to having a thrombus. And the reason for that is when the catheter is put into the artery, as this cartoon depicts, we're inflating the balloon to very, very high pressures. And by doing that, we release tissue factor and other molecules. And this stimulates thrombin generation, platelet activation, and usually, particularly in patients with acute coronary syndrome, there's a lot of inflammation around this vulnerable plaque. And so we treat these patients with anticoagulants, either indirect thrombin inhibitors or perhaps direct thrombin inhibitors. We use antiplatelet agents, and we give high-dose statins. On this slide, we show just another diagram of the balloon catheter and how it's being inflated and reducing the atherosclerotic plaque that you see in the coronary artery. And on the right-hand side of this slide, we show what probably the majority of patients receive, and that is a stent. And so a stent is a metal device that once it's inflated, it's sort of propped open, and then it remains open, and it helps keep the vessel open. This diagram shows all the different sites of action of the antithrombotic drugs. On the left-hand side of the slide, we have a sort of a simplified version of the clotting cascade. And you can see where the low molecular weight heparins and heparin act with antithrombin, which affects factor Xa as well as thrombin. If for some reason the patient cannot receive a heparin type product, then we might use direct thrombin inhibitors. The ones that are usually used in the cardiac cath lab are bivalrudin or argatroban. And these agents, these anticoagulants, help inhibit the progression from thrombin to fibrinogen to a fibrin clot. On the right-hand side of this slide, we show really the role of the platelets. And platelets are activated by a number of different agonists: collagen, ADP, thromboxane, all of these particular agonists will cause a conformational change in the platelet itself, and that leads to platelet aggregation, which also is one of the foundations of a thrombus. And so we can see where we have the ADP inhibitors, clopidogrel, prasugrel, ticagrelor, which I'll be discussing. Ticlopidine is an older product that's really not used due to its effects on bone marrow. And then in the cath lab, we will sometimes use glycoprotein 2B3A inhibitors, such as epsiximab or integralin. So again, many of these patients who have acute coronary syndrome are going to go to the cath lab, probably the vast majority of them, and they will undergo a PCI procedure. There are a number of complications associated with PCI. One problem was when you inflate the balloon catheter, that within minutes to hours, sometimes the coronary artery would sort of recoil and contract down. And that has generally been addressed by using stents. And the picture of the stent that I showed earlier helps prevent that elastic recoil, and so it keeps the artery open. However, by using a stent and putting a metal device within the coronary artery, you're causing platelets to be attracted and to become reactive to that metal. And so it's very thrombogenic. So one of the biggest problems that we have is the formation of a thrombus within the stent itself, and that's called in-stent thrombosis or stent thrombosis. And that usually happens within hours to days of the stent being implanted. So it's very, very important for patients to begin their antiplatelet therapy immediately after the procedure. Now, we've also come to realize that in most cases, within weeks to a month or a few months, the blood vessel will have a layer of endothelium that will cover all these metal struts that are part of the stent. However, in some patients, this is delayed for reasons that aren't really that clear, and there have been cases of in-stent thrombosis months, and there's even been reports of in-stent thrombosis occurring more than a year after a stent has been placed in the coronary artery. So in-stent thrombosis is still something that we need to be concerned about. Another problem that was a result of putting in the stent was the proliferation of vascular smooth muscle. I mentioned that, usually a layer of endothelium will sort of grow over the stent. However, in some cases, there was a much greater degree of vascular smooth muscle to the point where restenosis would occur. And that has been primarily addressed by using drug-eluting stents. So drug-eluting stents have medications that are in the stent that sort of inhibit this cell proliferation. And by putting the drugs in the stent, then you are preventing restenosis. Now, the drugs that are used are sirolimus or paclitaxel or drugs of that type that are in within the stents themselves. Because of these drugs, it's taking much longer for the body to epithelialize the stent. So dual antiplatelet therapy with aspirin plus usually a thienopyridine is recommended for at least 12 months following stent implantation. So we're trying to prevent these late occurring episodes of in-stent thrombosis because there have been instances where patients have had acute myocardial infarction and even death due to the in-stent thrombosis. So in-stent thrombosis, luckily, is a rare complication, but we do worry about it quite a bit because it is potentially lethal. And now I'd like to pause for a minute for a poll question. I'd like to present you with a patient case, and I want you to think about this case as we go through the rest of our slides. This is a 53-year-old man who presents to the emergency department after complaining of 2 hours of chest tightness, and his ECG reveals ST segment depression. So he is showing signs of ischemia on the electrocardiogram, and certainly his symptoms go along with that as well. He has a past medical history significant for gastroesophageal reflux. He also has dyslipidemia, and he's currently taking omeprazole and atorvastatin for those conditions. He's taken to the cath lab later that day and receives a drug-eluting stent in his left circumflex artery. So I'd like to ask your opinion now regarding this patient. What medications should he receive at discharge? Thank you for your participation. Well, let's continue now with the presentation, and perhaps some of these points will become clear. Now, just to review briefly, now this patient did not have a STEMI because he had ST segment depression, not ST segment elevation. But I did want to just briefly review the 2009 guidelines with you, and because he did undergo a PCI, he still falls under these guidelines. And the guidelines are that patients should receive a loading dose of a thienopyridine, and the recommendations are either 300 to 600 milligrams of clopidogrel or 60 milligrams of prasugrel. And they do make a note, and we'll discuss this a little bit later, but if a patient has a history of stroke or a TIA, then prasugrel is not recommended. What about the duration of therapy? I mentioned before that in patients who receive a stent, and it doesn't make any difference whether it's a drug-eluting stent or a bare metal stent, the most recent update of the guidelines recommend clopidogrel 75 milligrams a day or prasugrel 10 milligrams a day for at least 12 months. And this is new, or this is somewhat of a revision of the guidelines in 2009. Prior to this, if someone received a bare metal stent, the recommendation was to receive a thienopyridine for 30 days. And so now we've increased that duration out to 12 months. So again, it's really dual antiplatelet therapy because they would be on aspirin, but the new focused update dealt with the duration of therapy for the thienopyridine. Now they do also comment in the guidelines that if the patient is at a high risk of bleeding, then you can shorten the duration of therapy for the thienopyridine. And you'll notice that on the slides, there's levels of evidence, and the levels in these particular guidelines are A, B, and C. A means that there are a number of randomized prospective controlled trials, whereas with level of evidence C, it basically means this is the opinion of the experts, and level of evidence B is somewhere in between. There may be just one randomized trial instead of multiple randomized trials. So here we have a diagram, again, just showing the different ways that various antiplatelet agents work in terms of preventing the platelets from doing that initial step in hemostasis. So the first thing is that the platelet has to be activated. And again, on the right-hand side of the slide, we see collagen, thrombin, thromboxane, ADP. All of these agonists cause the platelet to go from sort of being quiescent into a very reactive cell. And when the platelets are activated, the glycoprotein 2B3A receptor, which is in green, these receptors are externalized on the surface of the platelet. And the glycoprotein 2B3A receptors are very important because they are able to link the platelets together by forming little bridges with fibrinogen, circulating fibrinogen. So platelets, before they can start sticking together and forming like a platelet plug, they have to be activated. So many of our drugs are really geared toward preventing platelet activation to begin with. So we have aspirin, which inhibits the formation of thromboxane A2, and we have the thienopyridines, such as clopidogrel as an example, that blocks the P2Y12 receptor, and that's demonstrated on top of the cell, and that's where ADP works. So there's two different mechanisms. So again, just to review the mechanisms of action, clopidogrel is a thienopyridine. It does inhibit the binding of ADP to the P2Y12 receptor. This is an irreversible process, so that the platelet is inactive, or that particular pathway or receptor is blocked for the life of the platelet, which is usually 7 to 10 days. Clopidogrel has been shown to be effective in reducing atherothrombotic events that are associated with MI, stroke, peripheral arterial disease, and acute coronary syndrome. Now, there are some drawbacks about clopidogrel therapy. It is a prodrug, meaning that it has to undergo a metabolism in order to become active. And there has been a lot of literature within the last couple of years about the genetic polymorphisms, particularly on the CYP2C19 metabolic pathway, and that's one of the major pathways that clopidogrel uses in order to become active. There's also been a lot of literature about a drug interaction affecting this particular pathway with proton pump inhibitors. And because it's highly controversial, I'd like to review some of that data with you. Now, this all became really apparent in 2009 with the publication of this particular manuscript in JAMA. What was done in this study was a retrospective look at over 8,000 VA patients who had a diagnosis of acute coronary syndrome, and they were prescribed clopidogrel after discharge. And what the investigators did is they wanted to look at all-cause mortality or the need for rehospitalization for another episode of acute coronary syndrome. Now, many of the patients, as you can imagine, might have had some history of GI disease. And so actually, the majority of patients, or 5,244 patients, were discharged receiving clopidogrel and a PPI. And then almost 3,000 were discharged on clopidogrel alone. And so you can see those two columns. Now, on the left-hand side of this chart, you can see the outcome measures in the study. So the primary endpoint was death or the need for rehospitalization due to another episode of acute coronary syndrome. And you can see that in the fourth or the second column from the right is the adjusted odds ratio. And you can see that there was about a 25% increase in the patients who received the combination of clopidogrel and PPI with this composite endpoint. And this was statistically significant. The second, or I guess the third row down, you can see one of the secondary endpoints, which is just the rehospitalization for ACS. And you can see that it was more than doubled in the group that had the combination therapy. And if you look at the bottom row, that's the endpoint of all-cause mortality. And there was a trend, but it was not statistically significant. And so the primary endpoint was primarily driven by these rehospitalizations for ACS. Now, because this is a VA, it has a fairly restrictive formulary, and so the PPIs that were primarily used were listed at the bottom of the slide here, and the majority of patients were receiving omeprazole. Now, since that particular manuscript was published, a number of other individuals or groups have looked at data. Most of these are retrospective analyses. The one by Stanek was a look at a large database of patients who were receiving clopidogrel. In that particular instance, there were 6,800 patients who were on a combination, and you can see the breakdown of the various agents on the right-hand side of the slide. And he also found an increase in the hazard ratio when he looked at the pooled data. There's also the Jurlink study also found an increase, and they used an odds ratio of about 1.27 for people that were receiving clopidogrel in addition to a PPI. They made the note in their paper that they did not find an association, however, with pantoprazole. And again, you can see that, of these 5 trials, 3 of them found a relationship, 2 of them did not. And just sort of to summarize, there's been a lot of data, but it's not been consistent. The Credo study was a study looking at clopidogrel when it was one of the pivotal trials to get the dosing established for clopidogrel. And in this particular study, after a period of time, people received bare metal stents, and so they were on clopidogrel for 4 weeks. Then they were randomized to either placebo or clopidogrel. And so there were a number of people that were also on PPIs with clopidogrel and also with placebo. And what was interesting in this particular retrospective analyses was that they suggested not only an increase in death, MI, or stroke in the combination of clopidogrel plus a PPI, but there was also an increase in death, MI, and stroke in the people that were on placebo plus PPI. So that raised the question, well, is this really a drug interaction with PPI and clopidogrel, or is there something that PPIs are doing in and of themselves? So that leaves us still wondering about what the reasons are for this increased cardiovascular risk, the increased potential for another acute coronary event. And it's possible that PPIs do interfere with the production of clopidogrel's active metabolite, and so we're decreasing the efficacy of the drug. This post hoc analysis from the CREDO study might suggest that it's PPIs themselves that are actually causing some harm. And a third possibility is that what we're really seeing are confounding variables, and really that the patients who were receiving the PPIs were older or sicker, or had some other reason to be on them. Since these were not randomized trials, we really don't know the answer. So in summary then, we have observational data. Some observational data suggest an association between PPI use, particularly omeprazole, and increased cardiovascular events in patients receiving clopidogrel. But it's not consistent. We also have a post hoc analysis that suggests PPI use just by itself is associated with an adverse cardiovascular event, irregardless of clopidogrel being used. And then most recently, we have a randomized trial that looked at a combination product, which is not available, and it did not find an increase in cardiovascular events, although that particular study might have been underpowered, and it was halted early. I would point out that in November of 2009, the FDA came out with a release recommending avoiding using omeprazole in combination with clopidogrel. And they went further in this news release, which is kind of down at the bottom of this slide. And they made the point that other drugs should not be used with Plavix if they have a similar interaction with the C2C19 enzyme. And they made a point of highlighting esomeprazole, cimetidine, and then a number of other agents that are known to affect the CYP2C19 enzyme. Now, the most recent statement, and this was published online at the Journal of the American College of Cardiology in November of 2010, they have a number of points that they make about antiplatelet therapy. First of all, they say that dual antiplatelet therapy should not be routinely recommended for patients with prior ischemic stroke. So just, treating patients with prior ischemic stroke should not be getting dual antiplatelet therapy because of the risk of bleeding. Patients with a prior GI bleed are at the highest risk of having GI bleeding again when they're receiving this combination therapy. And they also point out that there are other factors to consider: age, concurrent use of anticoagulants or nonsteroidal drugs, and a history of H. pylori infection. They do say that PPIs are recommended for patients who have a history of an upper GI bleed, and they also make the point that these PPIs could be used in other patients if they have multiple risk factors for GI bleeding. However, they do not recommend the routine use in patients who are at low risk. So the routine use of PPI or an H2 antagonist is not recommended for your patient who's low risk that requires dual antiplatelet therapy. So what does all this mean? It really means that a clinician has to evaluate each and every patient and assess the risk versus the benefit of not only dual antiplatelet therapy, but if you're going to use dual antiplatelet therapy, what is the risk of perhaps attenuating the beneficial effect if you're going to add a PPI or an H2 antagonist. So I'm not sure that this is really helpful for people who like everything to be black and white, because it still is very much, I think, a gray area, but it does suggest that there's not one specific right or wrong way of doing things. Now let's go back to our patient case poll question and look at some other potential options. Again, we have our same gentleman who got the drug-eluting stent. Aspirin and clopidogrel were used. He has a history of GERD and dyslipidemia, so he's currently on omeprazole and atorvastatin. And now some other choices for you to consider. So take a second and let's see what our audience thinks about this. Thank you for your participation. Now let's continue on. There's also another agent available, and that's prasugrel. So I'd like to review prasugrel. Again, prasugrel is a new thienopyridine. It was approved in July of 2009. The pharmacokinetics of the drug are it's a prodrug. Its onset of action is quick, usually within 60 minutes. It has a short half-life, and the metabolism is different than clopidogrel. It's metabolized primarily by CYP3A4 and 2B6. Prasugrel is indicated for acute coronary syndrome that's managed with a PCI. So if you don't get a PCI, then prasugrel does not have an indication strictly for what we would call medical management. You need to have a coronary intervention. It's contraindicated in patients with a previous TIA or stroke. It's also only been studied in patients that were emergently receiving an elective PCI, so that it's not been really studied in patients getting an elective PCI, but they should be getting it for an acute coronary syndrome. In other words, the people that have stable angina that are just coming in electively, prasugrel has not been studied in that group. And the benefit in patients greater than 75 years of age or less than 60 kilos has not been proven, although it's been suggested using a lower dose for those smaller patients. The United Kingdom also has some guidelines that they have recommended using prasugrel only, again, for patients with acute coronary syndrome that are having a PCI. And they further say only in 3 circumstances, that it's for either an immediate primary PCI for ST segment elevation MI, or that the patient has a history of a stent thrombosis while they were receiving clopidogrel, or the patient has concomitant diabetes. So what is the data based on that prasugrel was approved on? And really it's the Triton TIMI 38 trial. And this was a comparative study with prasugrel versus what was standard dose clopidogrel. It was a very large study of patients with acute coronary syndrome who were scheduled for a PCI. It was an international study. They looked at using a loading dose of 60 milligrams followed by 10 milligrams a day of prasugrel. The clopidogrel patients received 300 milligrams as a load and then 75 milligrams daily. Again, they included either STEMI patients or what they called moderate to high risk unstable angina or non-STEMI patients. They excluded people who they thought would be at increased risk of bleeding if they had anemia or thrombocytopenia. They also excluded anyone who had any history of any kind of intracranial pathology, and patients who had received a thienopyridine within 5 days before enrollment. As far as the intervention itself, the whatever vessel, whatever device, any adjunctive medications, those were not controlled, and they were left to the discretion of the interventional cardiologist. All patients did receive daily aspirin. They made a recommendation of a dose of between 75 and 161 milligrams. And then the patients were followed routinely at intervals of basically 30 days, 90 days, and every 3 months thereafter. If we look at the primary endpoint for this study was a composite of death from cardiovascular causes, non-fatal MI, and non-fatal stroke. And you can see in the first row of this chart that there was almost a 20% reduction in that composite endpoint for the patients that were randomized to prasugrel. There was no difference in death from cardiovascular causes. That the major driver of this composite endpoint was the non-fatal MIs, and there was nearly a 25% reduction in non-fatal MIs. And then there were also some other secondary endpoints that were looked at: urgent target vessel revascularization and stent thrombosis, which were also reduced in the prasugrel group. There was no difference in non-fatal stroke between the 2 groups. So what's the safety? Because every drug has some adverse effects, and so we have a more potent antiplatelet agent, but what is the safety? And so they looked at a number of different endpoints regarding bleeding, and you can see that in every case, whether it was major bleeding that was not related to the patient going to surgery, life-threatening bleeding, fatal bleeding, minor bleeding, bleeding requiring transfusions, any way you want to cut the pie here, there was a statistically significant increase in bleeding associated with prasugrel. So when you take the better efficacy but more bleeding, there were a number of patient groups that they looked at and were able to come up with what's called a net clinical benefit. So the patients who did not have a history of stroke or TIA seemed to benefit to receive prasugrel even though there was higher bleeding. There was still overall a net clinical benefit in that group. Prasugrel was also favored in patients who were less than 75 years of age, weight greater than or equal to 60 kilos, and again, no history of TIA or stroke. And basically, you can see the hazard ratios, and the hazard ratio is 0.8, meaning that there was sort of at this 20% benefit. And again, that was statistically significant. However, if the patient had a history of stroke or TIA, you can see that the hazard ratio was greater for prasugrel, meaning that the net clinical benefit favors clopidogrel in that group of patients. So in conclusion, this study demonstrated that prasugrel, given in the dose that was described, was more effective than standard dose clopidogrel at preventing ischemic events. However, the trade-off was that you did see an increase in major bleeding. Now, this trial has also been looked at in a little bit more detail, and there was a study that kind of looked retrospectively at the two different groups. One group that were STEMI patients, and the other group that were either unstable angina or non-STEMI patients. And they looked at the deaths that were reported in this particular trial. And they found 18 fewer deaths in the patients who had presented with STEMI, yet there were 9 more deaths in the clopidogrel, there were 9 more deaths in the prasugrel group as compared to clopidogrel in the patients who were either unstable angina or non-STEMI. Now, again, this is retrospective data, but it's just kind of interesting, but I think it explains a little bit why the British group, the NICE guidelines, specifically recommend prasugrel in STEMI patients. That's where most of the benefit was seen. So prasugrel, the contraindications are bleeding and prior TIA or stroke. I'd also like to point out that it's not recommended for patients that are greater than 75 years of age, and that you should also consider a reduced dose in patients that are less than 60 kilograms, and they have suggested a 5 milligram dose for the maintenance dose in those patients. Now, getting back to our patient, there are some other potential options for us to consider. And one option is that we might want to do some genetic testing and actually see whether this patient has any of the polymorphisms that are associated with reduced efficacy. So again, the FDA has come out with a warning that's in the package insert now, and they say that patients who are determined to be poor metabolizers, those that have this polymorphism for this 2C19 allele, that these patients might have higher cardiovascular event rates following either acute coronary syndromes or following a PCI. The problem is they don't really tell us what to do about it. And so, the question is, should we increase the dose of clopidogrel? Should we switch to ticlopidine? Probably not. But should we switch to prasugrel? But what if the patient is over 75? What then? Or there are some data that actually have other antiplatelet agents, but there's really very little data, and there's nothing in the guidelines to suggest that. So at this point in time, we really don't have definitive outcome data on any of these options in patients who are determined to be sort of these non-responders or clopidogrel resistant patients. One other option that I think is viable is to actually measure platelet reactivity. And there is a device that's called Verify Now, or a Verify Now assay. The Verify Now assay is very simple to do, and there are two large trials that have looked at using the Verify Now assay, and they are able to determine which patients are resistant to clopidogrel. I'd like to mention two trials in particular that have used the Verify Now assay, which is a very easy point of care assay that is commonly being used in many of the hospitals. The first one is a study that was reported at the American Heart Association meeting in November of 2010. The Gravitas study looked at patients who were resistant to clopidogrel as determined by the Verify Now assay. And these patients were randomized to high-dose clopidogrel, which is 150 milligrams a day, versus the usual dose of 75 milligrams per day. And this study was important because it showed that there were no differences in terms of outcomes with myocardial infarction or in-stent thrombosis or bleeding for the patients who did receive the higher dose. So in some ways, people may say that this is a negative study because we didn't show any differences, but it did determine that using a higher dose of clopidogrel was really not beneficial. So I think it was very important from that point of view. The Trigger PCI trial is also using the Verify Now assay. However, in this study, they're randomizing patients to the usual dose of clopidogrel or prasugrel. And the results of the Trigger PCI trial are not yet available, so we'll have to see how that turns out. The last antiplatelet agent I'd like to briefly discuss is ticagrelor. Now, ticagrelor is not approved yet by the FDA, but it is being considered. And the trial, one of the major trials that looked at ticagrelor versus clopidogrel in patients with acute coronary syndromes was published in the New England Journal of Medicine in 2009. Now, ticagrelor is not a thionopyridine. However, it does act at the same receptor, so it does inhibit ADP from reacting with the P2Y12 receptor. But it does so in a reversible concentration dependent way. And that makes it unique because the other clopidogrel and prasugrel and ticlopidine are all irreversible. So ticagrelor could potentially have the benefit of getting fully recovering circulating platelets within 48 hours of stopping the drug. Some of the other advantages is it's not a prodrug, it's very rapidly absorbed, and it has its maximum platelet effect within 1 to 3 hours post-dose. So the Plato study, again, was a large study of over 18,000 patients. It was multi-center, randomized, and again, it was an international study. The primary endpoint was the time to occurrence of death from vascular causes, MI or stroke. And then another, what they called secondary efficacy endpoint, was to look specifically at the subgroup of patients who were undergoing a PCI. And of course, they also looked at major bleeding as well as minor bleeding. The patients were randomized to ticagrelor as a 180 milligram load, followed by 90 milligrams twice a day. The clopidogrel dosing was 300 milligram load, followed by 75 milligrams a day. And patients who were undergoing PCI after randomization also received an additional dose of the study drug, whatever that was. The aspirin was a 325 milligram load, then 75 to 100 milligrams daily. However, they did recommend 325 milligrams for the first 6 months in patients who received a stent. Patients were followed for 12 months, and they had another safety visit 1 month after their last study visit. So with the primary endpoint, 9.8% of the patients in the ticagrelor group versus 11.7% of the patients reached that endpoint. And these are the data from the 12-month visit. When we looked at that secondary endpoint in just the patients that had the PCI, we basically see the same reduction, about a 16% reduction, favoring the ticagrelor group. As far as other secondary endpoints, death from any causes, MI or stroke, again, was reduced in the ticagrelor group. Looking just at MIs, there was a reduction, again, about 15%, but there was no significant difference in terms of stroke. What about bleeding? The bleeding was, in essence, there were no significant differences in major bleeding. Life-threatening bleeding was the same, 5.8% in both groups. There were some differences in terms of some other side effects. The patients receiving ticagrelor had a much higher incidence of dyspnea, and that did reach statistical significance, as well as in the first week, there were more patients who had a 3-second or more ventricular pause. So to summarize the Plato data, we saw a significant decrease in primary endpoints, and it occurred both in patients that were managed medically as well as those that had a invasive strategy. They saw that benefit at 30 days, and it continued to 1 year. And probably more importantly, they saw that benefit without an excess in bleeding. Now, there are some cons or some other things to think about with this study. And although I didn't show you the data, but there's a lot more data, and they slice and dice the data a lot of different ways, but they found no significant benefit in patients that were living in North America. So as I mentioned, this was an international study. There also was no benefit in patients who were not receiving lipid-lowering therapy at the time of randomization. So whether these are real differences or whether these are just statistical flukes, we don't really know. It's hard to say. I think another potential limitation for both the Plato study as well as the Triton TIMI 38 trial was that the dose of clopidogrel that was used as a loading dose was 300 milligrams. That was the standard of care when these studies were designed. However, more current practice is to give a 600 milligram loading dose. And so you have to wonder, was it really, kind of a fair comparison? And then lastly, I would point out that more patients in the ticagrelor group discontinued therapy. I'd like to finish by really highlighting what the secondary prevention measures are and how as pharmacists we can be involved in the care of these patients. First and foremost, all patients who have had a percutaneous intervention and stent, the recommendation from the American Heart Association is that these patients receive 162 to 325 milligrams of aspirin for at least 1 month following a bare metal stent, or 12 months following a drug-eluting stent, and then the dose can be reduced to between 75 and 162 milligrams indefinitely. And that's a class 1 recommendation. Now, if the patient is deemed to be at higher risk of bleeding, then a lower dose, the lower dose can be used during the initial period following stent implantation. And the level of evidence for that is C, meaning that that's really just expert opinion. There are no trials or no real evidence to prove that. So in addition to lifetime aspirin, for patients that have received a drug-eluting stent, clopidogrel or I guess now prasugrel can also be considered. But they should be on dual antiplatelet therapy for 12 months. Now again, if the patient has received a bare metal stent, they need to be on a thienopyridine for a minimum of 1 month. But ideally, it would be 12 months. So unless the patient is at increased risk of bleeding, we definitely want them to be on dual antiplatelet therapy. There's also some additional data based on a trial where STEMI patients did not go to the cath lab and did not get a stent. And that particular study showed an additional benefit using clopidogrel in addition to aspirin and other medications typically used in STEMI patients for 14 days. And so that also has a class 1 recommendation, meaning that you should definitely consider doing that. Most patients that are STEMI patients probably do go to the cath lab and get a stent. But if they don't and they're treated medically, then think about adding clopidogrel for at least 14 days. And it's also reasonable to consider long-term therapy for 1 year. Again, that's a level of evidence C. Another class of drugs that we use for secondary prevention are the beta blockers. And so the beta blockers should be started and continued indefinitely for all patients who have either had an MI, acute coronary syndrome, or have a history of left ventricular dysfunction. And by that we mean an ejection fraction less than 40%, unless of course there's a contraindication. So beta blockers have definitely been shown to prolong survival in all those instances. So this is a class 1 recommendation, level of evidence A. So everybody that falls into this category should be on a beta blocker. Other things that are recommended are to inhibit the renin-angiotensin-aldosterone system. So here the recommendations are if people have a ejection fraction less than 40%, or if patients have what we call a preserved ejection fraction, but they have hypertension, diabetes, or chronic kidney disease, again, an ACE inhibitor should be given. And they should also be considered for all other patients who are not at lower risk. And the other drug to consider in terms of blocking the renin-angiotensin-aldosterone system is an aldosterone antagonist, so spironolactone or eplerenone. As pharmacists, we can really take the opportunity to encourage patients to live a healthy lifestyle. So here, I would encourage you at every opportunity to re-emphasize smoking cessation for your patients. So smoking cessation, weight reduction, physical activity, and then just a healthy diet of fruits and vegetables, low fat, low salt. All of these things can go a long way in preventing the progression of coronary artery disease. The other things of secondary prevention are blood pressure control. We want the patient's blood pressure to be less than 140/90 and less than 130/80 if they have concomitant diabetes or chronic kidney disease. So good blood pressure control, encourage patients to monitor their own blood pressure. Hyperlipidemia, of course, is another major goal, and lipid control is our goal. So it's been recommended that if patients are not on therapy, to initiate therapy prior to discharge. Most of the patients are going to be on a statin, and so our goal is to have an LDL less than 100. However, an LDL less than 70 is very reasonable in patients with documented coronary disease. Diabetes is a very common concomitant disease, and so we also want to make sure that the patient's hemoglobin A1C is less than 7%. And lastly, since this is an elderly or older population, at the time of discharge, many of these patients need to take other pain medications. Many of these patients will have osteoarthritis or other types of joint pain. And so what's recommended, since this is such a common concomitant disorder, is to start with acetaminophen. If acetaminophen does not control the pain, to consider very small doses of narcotics or non-acetylated salicylates. And lastly, there is a class 3 recommendation, which means don't use it. So do not use the COX-2 selective agents when other agents are able to provide pain relief. So I'm going to end with that note, but I would like to remind everyone with the red dress that women have heart disease. It's not just a man's disease. Sometimes the symptoms for women are slightly different than men in terms of coronary disease. And so they may have more fatigue, they may have more non-specific types of chest discomfort. But please, please remind your female patients that women are more likely to die of heart disease than anything else. It affects 1 in 3 women. And so please encourage your female patients to be aware of coronary disease and encourage them in with the same aggressiveness that you would your male patients. Thank you.